Hello and welcome everyone to another video of Clinical Simplified Shorts. Today we will be studying one of the very important topics, one of the topics which is frequently asked in the exams, and there is very less to understand, there is more to remember. So the topic is congenital anomalies of the central nervous system, right? So let's start. First we'll be starting with neural tube defects or dysraphism. Neural tube defects are the most common congenital CNS anomaly you will encounter whenever in clinical practice or in exam. Neural tube defects, questions from neural tube defects you will encounter, right? Neural tube fails to close between the third to fourth week of intrauterine life, resulting in neural tube defects, right? Most common site is the lumbosacral region. It has a very high incidence in North India, right? And mind you, folate supplementation reduces the risk by 70%. Coming to the recurrence risk, these are all questions. So I have made them in a table wise manner. Recurrence risk, first child 3.5%, second child 10%, and third child 25%. This is the recurrence risk. Only to remember, nothing to understand. What to understand here? Okay. Etiology, zinc and folate deficiency, maternal alcohol, radiation, valproate ingestion, carbamazepine. Valproate and carbamazepine are the drugs that contribute to neural tube defects. Maternal diabetes, trisomy 13 and 15. Prenatal diagnosis, how will we diagnose this prenatally? The neural tube is open that communicates with the amniotic cavity. The biomarkers, biochemical markers that will help us to detect antenatally neural tube defects are alpha fetoprotein and acetylcholinesterase. Okay, these are the types of neural tube defects. Very, very important. Everything you need to remember. You will remember, don't worry. I have put certain good images that will get imprinted in your brain. Just time and again follow this up. First is anencephaly. Anencephaly, you all would have known. Anencephaly is the absence of brain calvaria or the absence of the skull. Only the brain part is visible. A child is born with anencephaly. You can know it from a distance. Failure of closure of the rostral neuropore. 50% are associated with polyhydramnios. See, there is no brain, there is no skull. So the CSF that should be accumulated inside the skull is now roaming outside. So there is polyhydramnios. The okay, I'll be showing you the images. Don't worry. Encephalocele, herniation of the brain and meninges. Listen, encephalum is the brain. Okay, sorry. The herniation of the brain and meninges through a defect in the calvaria. The meninges would herniate, taking some amount of brain matter. That is called encephalocele. It is a bony defect in the skull. We'll be coming to the pictures. Craniorachis, anencephaly, understood anencephaly plus continuous bony defect in the spine. That was only in the skull. Now it is extended to the spine. Just imagine the picture in your brain so that you can correlate. Plus exposure of the neural tissue. Open brain plus open spine. So first of all, let's see these three pictures. See, this is anencephaly. No brain calvaria, only the brain matter. So there are high chances of infection. Usually the newborns with anencephaly do not survive. So antenatally, if we diagnose anencephaly, we can plan accordingly. We can plan and instruct the parents. We can make them understand the prognosis. For that, first we have to be clear about the prognosis, right? This is the encephalocele, herniation of the meninges and taking some amount of brain matter, encephalocele, right? This is the craniorachis. See, there is anencephaly. This part is the same. Along with it, there is an open spine and exposure of the neural tissue. This is the open spine. Okay. So understood? Anencephaly, encephalocele, and craniorachis. Now, iniencephaly, dysraphism of the occipital region, less important, but you have to remember. Dysraphism of the occipital region plus retroflexion of the neck and trunk. Extreme retroflexion of the head. So whenever a child is born with extreme retroflexion of the head, we term it as INICET. Then meningocele, meningomyelocele, spina bifida occulta. These are very common things. Meningocele, meningomyelocele, spina bifida occulta. Tomorrow you will be in a clinical practice. Some parents would be asking you, sir, my child has meningocele. What to do about it? Sir, what is meningomyelocele? These should be on the tip of your tongue, right? So meningocele, meninges herniate through a defect in the posterior vertebral arches. Okay. We will when you will see the pictures, you will get a clear vision of it. Meningomyelocele, the neural tissue, again the same thing, the meninges plus some neural tissue. Spina bifida occulta, the vertebral bony defect without protrusion of the spinal cord. Occult means it's hidden. Spina bifida occulta, whenever it's coming out, it is called spina bifida manifesta. Okay. So spina bifida occulta, vertebral body defect without protrusion of the spinal cord or meninges. So what will we see there? There would be patches of hair, lipoma, or a dermal sinus in it, typically in the L5S1 region. It is a defect in closure, but it is not manifested outside. It is kept occult inside. Okay. So these you read now. This is meningocele. First one is meningocele. This is meningomyelocele. This is spina bifida occulta. See. This is occulta, just a bony defect. This might be a dermal sinus or a tuft of hair, just a bony defect. This is meningocele, herniation of the meninges, no neural tissue. Mark the difference here. There is neural tissue. Okay. Herniation of the meninges along with neural tissue. It is called meningomyelocele, the sac of fluid with a damaged spinal cord. So accordingly, we need to explain the parents whenever we tell about a surgery in the meningocele or a meningomyelocele. There are different prognosis to the disease. Whenever we do a surgery of the meningomyelocele, we know that neural tissue is inside it. So in a surgery, there is a risk of damage to the neural tissue, right? So accordingly, we explain the prognosis. Understood? So what's the management? Mostly the management is surgery, nothing else to do. Closure of the defect and the BP shunt if there is a hydrocephalus. Open lesion should be closed within 24 hours. The more exposed the lesion is, the more actively we need to intervene. Closed lesions operate within 48 hours. What is Lorber's criteria? I mean, where you should say that actually surgery is not recommended. Severe paraplegia at or below L3, kyphosis or scoliosis, gross hydrocephalus, associated gross congenital anomalies, intracerebral birth injuries, and neonatal ventriculitis before closure. Remember this Lorber's criteria. There are certain questions that are asked on Lorber's criteria. You need to just remember things and exclude. Mostly these questions are, which are the following is not a criteria. Okay. Then how to prevent it? For general population, 0.4 milligram folic acid daily for all women of childbearing age. For high risk women, what are high risk women? Women with previously affected child. 4 milligram. The 0.4 milligram for the general population and 4 milligram, that is 4000 microgram for folic acid daily. When to be started? Not before pregnancy, before conception. 1 month before planned conception, we should start folic acid 4 milligram, and to be continued at least 12th week of till 12th week of gestation. Why 12th week of gestation? Because the new relation is complete by 12th week of gestation, right? Now understood these all things. Neural tube defects, mostly neural tube defects you will be coming across: anencephaly, encephalocele, craniorachis, iniencephaly, then meningocele, meningomyelocele, and spina bifida occulta. I hope you would not make a mistake on these whenever questions are asked. Now coming to forebrain anomalies. What are forebrain anomalies? Disorders in the cortical development. These are forebrain anomalies. Let's see. Lysencephaly. These are maybe relatively new terms, but when you do it again and again, you get to remember it. Lysencephaly. We come across cases, not that it's only in the book. We come across cases. We explain the parents. In fact, sometimes the PGs don't know these type of things. I mean, you must have read, but you would have forgot it by then. Lysencephaly or agiria. What is agiria? Absence of cerebral convolutions. The cerebral convolutions are absent. Poorly formed Sylvian fissure and associated with livet. Only remember, lysencephaly is agiria. All the cerebral convolutions are lost. There is a clear plain brain. Okay. Then cygencephaly, unilateral or bilateral clefts in the cerebral hemisphere due to morphogenesis abnormality. Cleft surrounded by gray matter. Remember, lysencephaly is agiria. Whenever you will see the pictures, you will relate. Just remember now. Schizencephaly is a cleft in the cerebral hemisphere. Porencephaly. Porencephaly is a cyst or cavity from the within the brain. Porencephaly is within the brain, right? Holoprosencephaly, defective cleavage of the hollow of the prosencephalon. Severe forms, leave it. I am showing you. So first of all, let's see lysencephaly, schizencephaly, and porencephaly. See, this is, you say, what is this? This is schizencephaly. You see a cleft, unilateral or bilateral cleft. Okay, this is, see, these are the convolutions. These are the convolutions of the brain. See, everything is lost. It is a plain brain. Okay, what you saw here, lysencephaly or agiria. This is the agiria part. These all convolutions are lost. So this is agiria. This is schizencephaly. Now this is a cyst surround within the brain. This appears from one side, unilateral, but this porencephaly is a pore. Remember, porencephaly is a pore within the brain. Okay. See, these are the gray matter. It is surrounded by the gray matter. Okay. Gone. Now, holoprosencephaly. Holoprosencephaly is the defective cleavage of the prosencephalon. Prosencephalon, mesencephalon, rhombencephalon. So this is the prosencephalon forebrain, the defective cleavage of the forebrain. The severe forms may lead to midline facial abnormalities plus cyclopia. Forget it. Pachygyria. See, this is agyria. This is pachygyria, means less gyria. The convolutions have decreased. In agyria, the convolutions are absent. Polymicrogyria, there are many small convolutions. Small, numerous, irregularly formed cerebral convolutions, localized tissue injury at the end of neuronal migration. So let's see. This is holoprosencephaly. The forebrain. This is the forebrain. This part is the forebrain, right? So there is a defective cleavage in the forebrain, prosencephalon. So this might be lobar type. This might be semi-lobar type. This might be alobar type. Okay. So just remember the names and remember the diagram of holoprosencephaly. See, this is polymicrogyria. Mean small convolutions, and there is a defective cleft formation. This is the polymicrogyria. Okay, these are the forebrain anomalies. Remember, the questions are mostly asked from lysencephaly, schizencephaly, porencephaly, then pachygyria, polymicrogyria. Just remember, but they will confuse you within schizencephaly and porencephaly. Unilateral cleft, another one is a pore. Then come to agenesis of the corpus callosum, Aicardi syndrome. What is Aicardi syndrome? Aicardi syndrome, a syndrome is always an association of multiple things. Just like in Aicardi syndrome, there is a lack of corpus callosum in the brain. Corpus callosum, the commissural fibers of the corpus callosum are absent in the brain. Holes in the retina. So mostly how we clinically pick it up, absence of corpus callosum may lead to seizures. Along with that, infantile spasms. Okay, agenesis of the corpus callosum and infantile spasm. It is a X-linked dominant inheritance. Seizures which are typically resistant to anticonvulsants. When will the anticonvulsant work? If there is an anatomical abnormality, anticonvulsants are very less likely to work, right? EEG independent, on EEG we see independent activity of both hemispheres. That is absent corpus callosum because the hemispheres are not connected to each other. And hips arrhythmia. Hips arrhythmia is a typical feature of infantile spasm. All patients result in severe mental retardation, can have hemivertebra. Retinal abnormalities, there are circumscribed pits in the retina. There may be coloboma of the optic disc, things to remember. So now you will not see cases of Aicardi syndrome. The only way you have is to remember Aicardi syndrome. Okay, agenesis of the corpus callosum, retinal pores or pits or coloboma. Third, we come to infantile spasms. Infantile spasms means hips arrhythmia. Then agenesis of the corpus callosum means independent activity of both the hemispheres. So resistant to anticonvulsants. So questions will be asked like this. Bat wing deformity in the radiological imaging. Then agenesis of the cranial nerves, Mobius syndrome. Mobius syndrome results in hypoplasia or agenesis of the brainstem nuclei. Sometimes the patient lands up in bilateral facial weakness, most often with paralysis of the abducens nerve, teratogenic effect of mesoprostol. This question was once asked in the NEET exam. The mesoprostol leads to Mobius syndrome.